So I think we're going to get started. I want to welcome everybody to our webinar series, Reducing Risk for Child Maltreatment and Treating Its Consequences, a national training series on the application of causal science. This is our second session. For those of you who came to our first session, we're really excited that you came back. And for those of you who are new to this, our first session is available online, and we actually, after this webinar, and we send out the video from this webinar, we'll also include the first one so you can get caught up. The first session really did focus on kind of the basics of causal data science and how that applies to children. And this session is going to really focus on what practitioners need to know to help maltreated children and their families. So we're going to be a little bit closer to like on the ground. Still pretty science heavy, but a little closer to on the ground. So we're really excited to have all of you here. Glenn, if you could move to the next slide, please, that'd be fantastic. All right, just a couple of housekeeping things before we dive into the content today. The slides will be available after the webinar. And one thing I will start with is we are doing this as a Zoom meeting so people can ask questions live with their voices. But I will also highlight that because it's a Zoom meeting, that means you have the ability to take yourself on and off mute. So I would ask everyone to keep themselves on mute when they're not talking. You can have yourself on camera or off camera as you would like, but please keep yourself on mute. So after the webinar, the slides will be available. We'll send out to everybody who registered for the webinar. We'll send out the slides, and it's also being recorded, and we will send that out to you as well. This slide is inaccurate, actually, because it says it's a webinar, but it's a meeting. So please keep yourself on mute. You can throw things into the chat over the course of the webinar. If there's a question or a comment that you have during the webinar at any point, feel free to throw it into the chat. We're keeping track of all of that in the background, and so we'll log all of those and bring those questions up. Dr. Sachs is going to have a couple spots where he's going to ask for feedback and people's thoughts. So at that point, when he opens it up, if you want to say something via chat, throw it in the chat. If you want to say something by talking, just raise your hand, which is down on the bottom. You can raise your hand, just raise your hand, and via the webinar, not via your own actual hand. And we will call on you, and you can ask your question or make your comment. I think with that is the housekeeping. If we want to go on to the next slide, we're not going to have everybody go around and introduce themselves like we did last time, but this is the faculty that's associated with this webinar series and also with the CHAMP Center and the CHAMP Network as well, which Kate Sullivan leads. So I believe with that, I'm going to turn it over to Dr. Glenn Sachs, who is going to present today.
Well, thanks, Andy. So welcome back, everyone. Really excited you're here and really excited to share with you what we have to share with you today. And so, as you know, as we talked about last time, we're talking about causality, causal science, all of that from the framework of what the ground, what clinicians, what practitioners need to know to help people. So this session is going to be focused on practitioners, children, families, what's needed, because that builds the case for causal data science and for a sort of science that is needed to add value to the work. So with that, the goal today, we'll review key concepts from last time so that we're all on the same page. If people have joined us and missed last time, it's good to be grounded in the concepts. And then for those who were here last time, this will be a good review. Then I'm going to talk about how we generally practice and where causality might fit into that practice. I'm going to then go into diagnosis and how important it is and problems with it in the current practice. And then talk about personalizing practice, which is absolutely indispensable in cases of multi-causality, as I'll be talking about. So here are some disclosures. about my support. And here's a review. So remember, last time we defined child maltreatment outcomes. These are deleterious events that undermine safety, development, health, mental health, adaptive functioning that have to do with maltreatment exposure or their consequences. So this is what we're aiming to prevent. And so the two categories, exposures, consequences, and you could see examples of that. Now, I defined what's in the middle of everything in practice, and it's really two things. When you're seeing someone, a kid, family, is she at risk for a bad maltreatment outcome? If so, what can I do to reduce the risk? 1 and 2, and I defined 1 requires predictive knowledge, 2 is very different, requiring causal knowledge. And then I defined, and this is, let's all be grounded in basic definitions because everything builds on top of this. If you see 2 variables, 2 factors, A and B, A would be any risk or protective factor, B could be any maltreatment outcome. Let's think of the difference between predictive and causal knowledge. For A, factor A predicts B if knowledge about it informs knowledge about B, and we see statistical associations, correlations, etc. And clinically, it's the use of assessment information to classify an individual for their risk for a maltreatment outcome. And that's very different than causal knowledge, where factor A is causal of B if the value of B is dependent on the value of A. And this all has to do with interventions. So if B is dependent on A, then if I intervene on A, B can change. However, if B is not dependent on A, I could intervene all I want and B will never change. And so there's many ways that A can predict B without being causal of it. And that's an essential thing to understand for this training series. And, I defined why this is through the common cause principle. Any factor that's an effect of a cause of another variable will be observed to correlate with that variable confounded by their common cause. I talked about lung cancer and yellow fingers, which correlate, and that correlation would be replicated in any study. And of course, there is a common cause, smoking. And this is built, this triangle of these 3 variables is critically important. And when we talk about multi-causality, boy, is it important. And I showed you an example of how this works, how confounds work in observational data. I was telling you about this Stithal meta-analysis of child physical abuse and 29 factors in this meta-analysis, multiple studies, and showing how easy it is for these factors to be confounded and misguide our approach to intervention. And then I reviewed problems with the state of our knowledge, and it boils down to a misalignment, a poor alignment between how we generate knowledge and the needs for knowledge, and that causal knowledge can really help in distinguishing predictive from causal. And then I noted that all of us here in this training series, all the participants, we have such a diversity between practitioners, administrators, scientists, and everyone is necessary. So I'm really looking forward as we move ahead in this series to get people's input, to have people roll up their sleeves and wrestle with the ideas, because everyone is important to move us forward. And it's all about scaling the translational wall. We have our science, as we read about in our literature, then we have our practice and what's needed, and we have this wall, and that wall needs to be scaled, and we really believe that predictive and causal knowledge is indispensable for this. Okay. Oh, and the last thing, because this I'm going to be referring to again and again in this series, I want to define effective care requires the capacity to make accurate predictions of maltreatment outcomes under intervention conditions and to learn from the predictive results. So we gather our data, we then decide what it means. We want to reduce risk or say this person doesn't need intervention, but it's all about predicting outcomes under intervention conditions. So we intervene because we expect things will get better. It's a prediction. Then we intervene if necessary. Then we look at what happens. We compare results about what happens to what we predicted. And then we refine our understanding and our approach to intervention based on that, especially if there were prediction errors. So this is going to be a central thing that we return to again and again and again. And, we have to get everything aligned. So let's define how we practice. And I understand, of course, everyone is different and practices differently. So I'm making some general comments to build the case for how things could be adjusted differently. So a general principle, we gather clinical assessment data to lessen the risk for maltreatment outcomes for if we decide there is a risk, intervention. So we start with clinical assessment. We get to maltreatment outcomes. This is a long way to get there. How do we get there? Well, we have to make clinical decisions. So how does this fit together? What to assess? That's the question. What would be most informative for our clinical decisions? And I'm just going to give some examples of what we might assess, but this becomes critically important because whatever we choose is our material for making our decisions. Does she have symptoms that will help us diagnose a mental disorder? Do either of her parents have symptoms for this diagnosis? Has she been exposed to a particular social factor or trauma? Is she a member of a particular demographic group? Does her family have a current or previous child welfare service plan? Does she carry an allele for a particular gene? Does she have an unconscious conflict or a particular defensive style? Does she have a particular brain imaging finding? You could see this is all about information, and anything might be relevant or irrelevant. So we have to be very careful in the limited time we have for assessment, what would be most informative, because this leads to our clinical decision. And then it's the time we're seeing someone to make these decisions, and then what's going to happen. It's all about time and can we intervene in time? And again, these definitions are about the use of the information for certain purposes. And now let's think, what does our literature tell us about what would be most important and how to use that? So let's talk about a kid and let's see how this might work. Here is Eddie. I'm going to tell you a little bit about him, but first, here is you or someone like you. A practitioner, again, has to make two basic decisions. Is he at risk for a bad maltreatment outcome? If so, what can I do to reduce the risk? Everything you do, if you're working with kids and families, is reducible to that essentially, if we want to be in the position of helping. So Eddie is an 8-year-old boy who has repetitive episodes of hitting, kicking, biting other kids and adults. Most recently, he ran as his teacher, knocking her off her stool. He has a history of physical abuse from his father and was brought to assessment by his mother for concerns about episodes of pushing teacher off her stool, kicking his soccer coach, biting another kid at recess at school. So, of course, his maltreatment outcome is aggressive behavior. That's our target for intervention. That's our target, and we need to figure out how to change that. So, be thinking now about, well, what information would you gather to help? Here's some further pieces of information. At times, it's hard for Eddie to sit still. His teacher reports he has to go to the bathroom too often. At times, he reports he can't focus. His teacher reports he daydreams a lot. His mother reports he has nightmares of his father hitting him. His mother reports that she believes his aggressive episodes are due to rejection sensitivity because of how much she observed his father rejecting him. He gets really anxious when he sees someone that reminds him of his father, and sometimes he even feels the belt landing on him that his father used to strike him with. Eddie's father is in jail now for assaulting other people. And his parents are separated, but before his father went to jail, Eddie was very anxious about visits with his father and tried really hard to avoid them. So we have to think about this, what it means, how we're going to help him. And, I wish I could say this was the most serious case I've ever seen, but I'm sure people, in the room here, um, this, if we're working with maltreated kids and families, these are the kids and families we're called to help. This is sadly, tragically, not an atypical case. And what that means is, what would you do? How do you think about it? And maybe I'll ask now for people either in the chat or even to say what does this make you think of? How would you begin to approach the case? What would you do with this information? Any thoughts?
So folks can throw it either directly into the chat. The chat just comes back to the moderators, but we will see it and read it out. Or you can raise your hand and we will call on you.
Must be someone out there with a thought. Anything's relevant. I'm waiting.
All right, we'll give people a little bit more time if they want to either raise their hand or throw something into the chat about what they would do.
If it's okay, I unmuted. I couldn't
Oh,
find.
perfect. Go
Oh.
for it, Karen.
I would
hear you.
probably look for and talk to Mom and Eddie too, teachers about pro-social behaviors and attributes that we can really highlight and celebrate. Focus a lot on the good to get some rapport building happen, for him to feel comfortable and safe, and then probably utilizing some child-centered play therapy with some collaterals with the parents so they can see opportunities for them to inflect that like into the home. Not every day. No parent can do child-centered play therapy all the time. But just to kind of incorporate pieces of that into the home so Eddie has those safe spots to land, you know, ever so often throughout the week.
Yeah, so part of it is engagement. Part of it, it's a really good point, is collecting more information that you might use through play and through more engagement to get other information. Now, how would it help you around our two essential questions about getting information to know his risk and how you might help him? And you don't have to answer, maybe if you're thinking about an answer, it would be, but everyone should be thinking about the information I might want to get. How would it help us for those two things? And I absolutely agree. Ultimately, helping him feel safer with you and also knowing more about the positives is going to be eventually essential, for sure. And we'll talk a lot more about that. Any other thoughts before I move on?
Hello, this is Quinta. I couldn't find where I could raise my hand. I apologize.
Thanks, sir.
I would want to, rule out any maybe organic reasons that could explain the behavior, any neurological issues if possible. I'm in community mental health, which is, it's not always possible to get a medical doctor or a neurologist to rule out. Maybe he's had a concussion in the past or a TBI from being beaten. So I would do that as part of the data collection. And then I would get a comprehensive history of his behavior, just to sort of pinpoint if maybe some of this behavior that we're seeing existed in his formative developmental years, or if there is a point in time where it started becoming more prominent.
Yeah.
Um, yep.
Those are great thoughts about getting more information that might be critical. And I'm assuming if you thought it was organic, that might help you know a little more about how that reduces risk if the organic cause was remediable. Maybe it's a seizure too, and or something like that you could intervene on. And also getting more detail about his history. So those are really good points. What about the information that we have right now in front of us? Is any of it relevant, we think, for how to help him reduce his risk for aggression? Anything that jumps out at anyone about any of the pieces of data that I've offered so far?
Well, this is Ann Wills. I also don't know how to raise my hand here. I can't see the button for that, but it seems like you mentioned that he seems to be having like intrusive thoughts about his father hitting him in the past. And so it seems like, he's got some, I mean, this seems like so obvious. I feel kind of ridiculous saying it, but he clearly has symptoms of post-traumatic stress disorder. And so, I mean, I would focus on, and he seems to be overwhelmed by those things. And so, I think about self-regulation skills, about how to regulate some of those symptoms. And like, in the classroom, I think, you, like he pushed over his teacher and he kicked the soccer coach. I suspect that there were, cues maybe that reminded him of his past experiences. And so I would want to do like a analysis of what specifically happened, which I mean, it seems like that's consistent with your approach to like really like look at, well, what exactly happened when that happened? Like, could you tell me more detail about that particular incident and and find out, well, like was there like a loud noises or something that precipitated those things? And
Yeah.
then try to address the environment, and then so that external environment, and then also build his regulation skills. Like sometimes, like when you hear those things, maybe you can, like go, or the adults in the environment can say, I forgot his name. Eddie, that's it, Eddie, like maybe you can go to a quiet place that we created to, like that.
Yeah.
I mean, you can't do that overnight, but like, build those things to deal with you know, his traumatic symptoms. I mean, he may be dissociating or something as well, something like that. And it will take time. So
Yeah.
those are my thoughts.
So those are really good points. You're using the clinical data here and thinking, this seems consistent with the diagnosis of post-traumatic stress disorder. That if that's the case, then there's probably triggers for it that you'd look for. You'd gather more data and think that it's the PTSD that's causal, is related to the aggression. So again, this is the exercise is about using clinical data and seeing what it might tell you about what you should do. So let's keep going with that. And again, our cycle here, we're gathering clinical data and then using it to say, okay, maybe I'll do this with it. And then the aggressive episodes will presumably get better. So I'll just start here by organizing the clinical data, and people have made comments that are consistent. And one of the things is I totally agree, there's more data to get. And actually, we're going to carry Eddie into the next session too, where I'll be talking a lot about other data. But let's talk about the data we have right now. Okay. So there's nightmares, inattention, rejection sensitivity, impulsivity, anxiety, hyperactivity, avoidance, intrusive memory. Okay, that's what we have so far. More data to gather, but might this inform us about what to do? Might any of it be causal? Because then we could use it to reduce the risk of aggression. And what about our how does our science help us organize this? So we might see that some of these fit together under a diagnosis of PTSD, as was just stated before. We also might see that other symptoms fit together, the triad of inattention, impulsivity, and hyperactivity is part of a diagnosis of ADHD. And then, this clinician, where this is a story about her, she might go to the literature and remember she read something, the ripple effects of trauma, valuing vulnerability, PTSD symptoms, and aggression with the child and adolescent population. Or she could look at ADHD and aggression, impulsive aggression, as comorbidity for ADHD in children, adolescents. So great. I think often in the world we try and arrive at a diagnosis and then that just points us to the intervention. So maybe she has it, or all of that. So how does this help us? Because this is often how practice works. So here's what she did based on what she understood, as I've just talked about. could organize the data into two diagnoses. Both are related to aggression. We also don't have to think too much, but we'll presume there's some processes that relate to this. Yeah, please mute yourselves. And then just to remind you about this, because it's so important, effective care requires capacity to make accurate predictions of outcomes under intervention conditions and learn from predictive results. So she thinks of the interventions predicting things will get better when she delivers them or refers for them. So she'll use TFCBT for PTSD. If she's a psychiatrist, she'll deliver methylphenidate, Ritalin, or Concerta, or she'll refer to this, and she'll expect things will get better. Our cycle here, right there. Deliver the intervention, predict next time you see Eddie, things will be a little better. So what happened? He's seen 2 weeks after his assessment, and he was perhaps a bit less hyperactive and inattentive, but he had 2 significant aggressive episodes. One in the schoolyard with those same kids. He was, as the mother said, doing typical boy stuff, yelling in schoolyard. Then Eddie kicked another kid with a provocation. The school monitor reported. Another episode at lunch, Eddie was slow to clean up his tray. He felt rushed by the lunchroom monitor, and then he angrily stood up, pushed the tray at her, and Eddie's drink fell over, staining her clothes. You know, how do we think Eddie is welcomed at school or around all these type of episodes? Kids like this tend not to be perceived very well in school, and that's a real problem. The other thing is anxiety and nightmares are unchanged. So, you know, you may see this, say, you know, I want to give it more time. Maybe you know, I'm not going to change anything. Maybe it'll take another few weeks for it to work, or you may want to look and see whether you missed something. That's all part of it. People, you know, some great comments said, should we look for organic causes? Should we take more detail about what happened? Should we look for other diagnoses? Should we, you know, collect more information? Should we do play to get more information? But part of it, again, is when things don't go as predicted, you think of what you missed. And that's just a really important thing here. And again, that fits here. Okay, you've intervened. Measuring the outcomes this is what I'm telling you, what the outcomes are. Then you compare results to your expectations, and then you decide whether you should be refining your understanding or whether you shouldn't have expected change to occur in this period of time. Okay. So what would you do? And I'll keep moving, but be thinking about that again, given this, because I want everyone to be in the space of, after you assess, predict, do something, an intervention, to be always ready to see what you may have missed and all of that. And it's also, how does our science help us to predict well? Because that's really our need, to be grounded clinically in what science, how it might guide us. So with that, I want to introduce the concept of the process that generated the data. Another word for this is the truth. You know, there is a process out there, whatever it is, that generated the clinical data or the research data. What exactly is it? Because we want to align as closely as we can to it so that we could predict well under intervention conditions. So what was the process that generated the clinical data? Here it is. Just take my word for it. Again, this is not a real case, but there is a process, and I want to say, well, what would this mean if this were true? And it's plausibly true, of course. So in this case, in the brain, there's a survival circuit. Let's say it's led by the amygdala, the hippocampus involved, the cortex in some ways. I could make it up, but there's a lot of literature about it. And this is set up by the experiences of physical abuse. Maybe certain kids are vulnerable through genetic predispositions. And then, as was mentioned in one of the comments, well, what about triggers? So a social factor, a traumatic reminder, clinically relevant, that leads to intrusive memories, which spill into impulsivity and then aggression. That's the path. What's also important is that there are other things here in the clinical data that if you were to intervene on them, like nightmares, hyperactivity, avoidance, anxiety, and attention, they're not going to change aggression. And that's very, very important as we move into what causality really is. It's so important clinically for this reason. What can you intervene on that will make a difference? And what could you intervene on that will not change at all? So these are intervention targets. Physical abuse and gene isn't changeable, so we need to be thinking about this. But then we need to be thinking about there are processes that confound our ability to see what's happening, that obscures our view. Because nightmares, hyperactivity, avoidance, anxiety, and inattention correlate heavily with aggression. Eddie reported this. If we look at a research article, we'll see these correlations, but they're not relevant for changing aggression. They're relevant for predicting aggression, but not changing aggression. That was the difference between predictive knowledge and causal knowledge. Why is that? Again, for the same reason. Because if you think of C as the survival circuit, and its line to B, aggression, goes through intrusive memory and impulsivity, A is, let's say, think of A as nightmares. Just think of this triangle. That's going to correlate, but it will be confounded, as I've said before. Same thing for all of these. See this process that generated the data, the truth. If you just look at it, you cannot intervene on each of these things to change aggression. So it's only on anything in green, if it's changeable, any that would possibly improve aggression. And that leads to a rule I want you to burn into your brain forever. If it's green, you can intervene. If it's red, get that out of your head. Everyone with me. If it's green, you can intervene. If it's red, get that out of your head. And again, with the 1 and 2 here, red is predictive. You could know about risk from red. It's not unimportant, but it completely misguides 2 about intervention to change anything. And that becomes so important. And so let's move into what happens with diagnoses, because it has to do with clustering and comorbidity. So if you think about A, B, and C in the triangle there, clusters of intercorrelations are to be expected and will happen if this is necessarily true. So all of this will intercorrelate with each other. Similarly, hyperactivity, impulsivity, and inattention will correlate with each other, which will, of course, justify our diagnoses, but also explains why our diagnoses are way less clinically relevant than we might think. Because if you look at what's in red, it's mixed. You might say, okay, maybe it's not ADHD, it's really PTSD, and the ADHD symptoms come from that. So intrusive memories lead to avoidance. They lead to hyperactivity because he's really active when he's having intrusive memories, etc. That's how it works. But again, in red, it's both ADD symptoms and PTSD symptoms. And similarly, in green, one of them is impulsivity, the other is intrusive memory. So if we use our diagnoses to totally guide our treatment, we're going to miss big things. We're not going to be able to, if we say it's PTSD, targeting avoidance isn't going to help. Even anxiety, it's only intrusive memory that goes into impulsivity. Again, if this model is the process that generated the data. So again, we think of our clinical utility here. So now let's dive into diagnosis a little more clearly. And let me just ask if anyone has any questions right now about anything I said, because I want to make sure that it's clear for people.
And Jenna put this in the chat, but you can raise your hand by clicking on react, and then one of the options is raise hand. Or if you just want to unmute or throw any questions into the chat, by all means, feel free to do so. And if we get questions, we will answer them. And if not, we will we'll keep going.
I just want to make sure that it's really clear because we're building on this every session.
I have more of a comment than a question, and I put it in the chat in the sense that when we look at what is considered a mental disorder, if we're going by diagnoses, we're essentially looking at being symptom-free. So we're looking at all those criteria and we're going, do they have that? Do they have that? Is there evidence of that? However, what I worry about is being symptom-free doesn't necessarily mean mentally healthy. So what I'm wondering about is that I think we're missing a causal framework of what mental health really is. Because only if we understand what causes mental health, then we have a better way of saying, all right, this variable and that variable may need to be targeted because it explains the aggression. And so that's what I'm struggling with.
Yeah, so it's a really good point. So I'd say two things about that. In a way, you could substitute aggression for anything else. You might say, however you might define mentally healthy for Eddie, you could put that in here, and then you would have the same problem still, because then you would need to collect whatever information you think would be most relevant for how you would improve his mental health, however you might define it. And I agree with you for sure. And in some of our studies, we're doing exactly what you're saying, because I think the focus on pathology is a limiting factor, no doubt about it. One reason I put, aggression here is because, this is, Eddie's undoing. It's really affecting his health, his mental health, his in school, how socially he's regarded. Obviously, we should be thinking as we think of interventions, what we may want to put, what positive things might we collect and fit in here. Again, in the next session, I'll be talking a lot about what might be missing and how that might really help you. So I'm building a case for some of what you're saying, for sure. But again, I want everyone to be thinking that whatever the outcome is, it's the same problem everyone has. What's the information that allows you to know what to do to make it better? And it's all about causality in that case. Does that help for what you were saying?
It does. I think it's just a foundational issue with mental health in general. The framework that we're operating on doesn't really have a causal definition of mental health. So that leaves us with the problem that you're identifying. Because my other thought was, if aggression was considered socially appropriate, this wouldn't be an issue then, because we can say, oh, aggression is not a maladaptive behavior, because, you know, in society, we think aggression is fine. Right?
Yeah.
So that's where I am, but I hear what you're saying, though. Yeah,
Well,
it helps a little.
No, I get the social construction, and I also get the paradigm focused on pathology misses big things. And in a way, you know, I'm looking for a different paradigm as well. And then hopefully we can all engage in thinking about it. But I'll also say, and I hope this will become clear as I lay this out, whatever paradigm we land in, causality is going to need to be in the middle of it. And we could talk more about it, but I think that's very true.
Agreed. Yep. Thank you.
Sure. Okay. So, and in fact, that's a nice lead up to some of the problems with our paradigm having to do with diagnoses. I've just shown you how diagnoses can be misleading because it misses the essential things, and it misses, like, it's based on the clustering of symptoms, which may or may not be able to be targets for intervention. So here's a definition to use for a diagnosis. The classification of patients, clients, people into groups defined by pathological processes. Again, this is pathology, but it's there in at least in medicine, there's a problem causing a problem. And this contributes to particular health risks to indicate interventions to lessen those risks. So many of us are in the mental health world, and in maltreatment consequences, we're thinking of exposure to maltreatment and mental health, mental disorders consequential of that. So that's really important, because how does that fit with this definition? Big problems. And so I want to lead into that discussion by talking about diagnoses in medicine and how this works and why it works and why it's so important to help people, improve their health. So I'll just tell you, 58-year-old man presents to an emergency room with exertional chest pain, nausea, and shortness of breath. These are symptoms. An EKG and blood work are ordered, revealing ST segment elevation. For people not in the medical world, that's an important sign on the EKG about heart attack and similarly elevated blood troponin levels. That's what doctors look for. And so a diagnosis of a heart attack or what's called acute myocardial infarction is made. So we have outcomes of heart attacks like congestive heart failure, arrhythmias, dangerous heartbeats, premature death, all of that. And we have these symptoms and signs that fit together. But those symptoms and signs are from death to a heart muscle, from lack of oxygen, from blockage of arteries. That's why these symptoms are there. None of them cause any of these outcomes. If you intervened on shortness of breath, you know, it's not going to help unless sometimes getting more oxygen does, or nausea, or EKG, all of this isn't going to help you. If you gave for chest pain like a painkiller, it's not going to help because these are the causal pathways. So again, red, green. If it's green, you can intervene. If it's intervenable, if it's red, it's not going to change things. And again, red and green. And this is all based on confounded associations. Now, that doesn't mean that what's in red isn't important. It has a role in the way we work with people, obviously, because this tells you, this predicts the outcome. It helps you know that myocardial cell death is going on, but you can't intervene. That's, again, the same difference between prediction and causation. And here's another case just to make the point. An 8-year-old girl goes to her pediatrician. She complains of fatigue. She complains of thirst and frequent urination, including bedwetting that just started. Blood test elevated blood and urinary tests, elevated blood, urinary glucose, and a blood test for high glucose, and a diagnosis of insulin-dependent diabetes mellitus is made. So again, diabetes causes peripheral vascular disease, diabetic retinopathy that can cause, blindness, all of that. This is diabetes, but we also see these symptoms and signs are not causally related. And diabetes is related to the autoimmune death, killing cells in the pancreas that make insulin that metabolize glucose. So insulin, you give insulin because of this, and it prevents the downstream outcomes of diabetes. It's the same thing. You can't intervene on any of these things. Here's where you might intervene. You certainly with insulin. So again, making the same point. And so we could look at the problem with our current diagnostic system. For mental disorders, what are the problems? It's non-causal. It's by definition in 1980 with DSM-3, psychiatry decided it shouldn't be causal because we didn't have enough causal information. Well, it's 45 years later, it's still non-causal, which is a massive problem. It's why, as we talk later in sessions, we'll talk about how to build the causal mental health through research that is able to discover causes with the type of data that we have. But what happens in our practice is we will typically conflate three distinct concepts that should be considered separately. Diagnosis is a cause. So you might ask the question, or Eddie's mother may ask the question to you if you were the clinician, why is Eddie so aggressive? And your answer could be, well, if you're using diagnoses in the way that DSM is organized, well, he's aggressive because he has PTSD and ADHD. I've talked about the problem. Diagnosis is outcome. What's your goal for Eddie's treatment? Well, I think this is one of the comments, which is absolutely true. Well, if our treatment works, he'll be symptom-free. He'll no longer have PTSD and ADD, which we assume will help reduce his aggression because we make lots of assumptions about correlates between diagnoses and lots of outcomes. And this is how diagnoses developed in medicine, in the history of medicine, a means of patient classification, which is different. The question, how can I use the clinical data to classify him into a category of risk for aggressive behavior, indicating how I could reduce the risk? And so to do that, Eddie has to be classified by causes. Now it gets more difficult with multi-causality, which really defines also why we need to personalize things. So I want you to think about any of the maltreatment outcomes I've talked about, and any that you know a lot about. So just think about the factors that you believe might cause it. Think of any sort of factor, developmental, social, different sorts of whatever it is for any of them, and think about how many factors. I think we could do a poll now even. Let's do the poll, Jenna. Can we do it? Yeah. Why don't people just, give your best guess of any of the maltreatment outcomes you know a lot about. Okay. Yeah, just whatever. It's don't sweat it. Okay. Some more people. Just put your best guess. This will be interesting. Okay. You have 15 more seconds, and then we'll close the poll. This is good. So we're seeing, multi-causality. Most of you and a lot of people, it's like 11 to 20 or over 20 even. Yeah. Some 4 to 10, so a lot of factors here. Okay, I'm gonna end the poll now. Okay. Okay. So we could see this. Okay, let's put our poll away. So yeah, we are in a multi-causal world, and many of you pick D or C, vastly multi-causal. So let's stick with that, and I'm gonna talk about what this means. And I haven't even talked about the interaction between causes. So the greater the number of causes, the greater the risk of false conclusions from research you might read about. And I've already defined this. So let's talk about the peril and promise of multi-causality. I'm going to start with the peril. Remember the common cause principle. Any factor that's an effect of a cause of another variable will be observed to correlate with that variable confounded by the common cause. We remember this, so we could substitute, heart disease. It's not just lung cancer, but I talked about heart attack. Yellow fingers because smoking is causal will have a confounded correlation with it. We can also think about, our story here, blood glucose is causal, but blood glucose causes urinary glucose, which is correlated. We also talked about the survival circuit, nightmares. It's not going to change aggression. That's confounded. And this, because we are in a multi-causal world, almost certainly, you all believe that, or almost all of you, this is our Bermuda Triangle, where we could get lost and never found again. So, and I'll tell you why that's true. So here's our Bermuda Triangle. Here's our maltreatment outcome. So any effect of this cause, maybe it's a survival circuit. We've already talked about that. Any of these any other causes, E, F, and G, any of their effects. So if we're reading, correlational studies in our observational literature, any of that, and then any of the upstream causes and, all of that. And so all of these are confounded. And then even something not measured in any study, it's still part of reality, part of the process that generated the data. So any of their effects will also be confounded. It's a massive problem. I know I haven't talked much to the researchers in the room, and I know there's several of you, but so let's then talk about the implications of this for a research study you might conduct. Let's say it's part of the process that generated the data. So let's just clean it up a little bit. Again, we know what red and green mean, right? So I'm not going to repeat it, but burn it into your brain. So just think about it. If you discovered that factor H had a highly significant correlation with factor B, how would you determine that factor E confounded it? Because you would need to know that, or else you'd write a paper talking about H's intervention implications, which happens so often. Or if you discovered that groups stratified by factor V yielded significantly different mean scores on factor B, how would you determine or rule out that factor P confounded it, making V predictive, not causal, and meaning nothing about intervention? This is the hardest one. If you discovered that factor R had a significant correlation with factor B, how would you determine that it was caused by an unmeasured common cause here? Because unless we can do this, our research isn't trustworthy for the reasons I'm talking about here. And in not next session, the session after, I'll be then talking more about methods to allow us to do this. But this is a teaser for this, and and something to talk to the researchers in our room about. So why does this model matter? Well, to predict the outcome, to know whether someone's at risk for an outcome, and it could be a healthy outcome, a positive outcome, whatever outcome you want, predicting it would be about all of this. But to prevent it through intervention, these drop out. Here's another thing, just because it's a cause doesn't mean it has an effect that's big enough that it will matter if you change it. So we have to measure and estimate the effects and the size of them. So let's drop out those that in this toy model, it's don't have a large enough effect. So these are your intervention targets. It also says that you had 20 statistically significant associations, which would replicate in every study because it's part of the process that generated the data. But you only had 7 causes with clinically significant effects. So we have to figure this out within our data, and that's what causal data science will help us with. And I'm just I wrote an editorial in the my voice is getting scratchy in the Orange Journal, talking about the research is in navigating a causal labyrinth, and that we need the sort of methods that could really rule out confounding in a rigorous way in order to navigate this labyrinth. But this also is the justification for why we need to be personalized, why we can't have an intervention like it's the same intervention for everyone with a diagnosis, because people are complex and their complexity is causal. That's why they're complex. So we have our model here, and this tells us something. Let's say we have 3 kids for a given outcome. Could be aggression, could be substance abuse, suicidality, or an outcome could be adaptive functioning. It could be doing well in school. It could be anything like that related to the complex people. Anytime you think that what contributes to this is multi-causal, you have to be personalized. And this is 1 and 2, as we've talked about, same thing. So 1, each of these will be predictive, telling you the risk, but to reduce the risk, we can't assume that everyone would have exactly the same ones. And so part of it is we assess every kid, and then we personalize the interventions based on that. In our last session, we'll be talking about work we're doing to create clinical decision support tools in order to personalize intervention based on knowledge of causes in a complex way. And, I'm just wrapping up here. I hope we'll have a good discussion, but again, I want to put this here about, I've gone over it, but this is something to burn in your brain, because even though our, as I've talked about, our science is lacking, to say the least, about causality, it's still, you could still use these ideas. And next session, I'll be talking a lot about how you use these ideas now to help the people you're working with. I'm going to continue with Eddie, so that, and to anticipate, we need better scientific knowledge, but even with knowledge we have now, we could move forward with it. So next session, how to treat Eddie through causal understanding, including assessing some of the things that people talked about today, and introduce a framework that can help guide assessment in targeting causes for maltreatment outcomes in your practice. I'm going to present an example of an intervention model that uses this framework, actually the model that I created with my team called Trauma Systems Therapy. We'll be talking about that next time. And I'll be presenting tools that you could use to implement the causal framework in your practice, whether you're using TST, trauma systems therapy, or not, or anything to give you some tools that will help. So why don't let's open this up for some questions or comments.
Thank you, Glenn. So you can, again, you can either unmute yourself, raise your hand by clicking on the react button and then selecting raise your hand, or you can throw any questions or comments into the chat. Quinta raised her hand. So by all means, Quinta, you can unmute yourself and ask your question or comment.
Dr. Glenn, Dr. Sachs, I apologize. I appreciate your
Glenn is fine. Don't apologize.
appreciate all the information. I look forward to the next session. For me, as a practitioner, I almost have in mind when I assess my clients or patients, depending on where people work, I almost want to put the diagnosis aside and then say, okay, what's the problem?
Yeah. Well,
because
yeah.
so that's sort of where I'm leaning, because I get a client referred to me because they were charged with so many, they have a legal problem, but then, okay, I have to do a diagnosis for the insurance companies, but the fact that they picked up a charge is not necessarily the problem. So that's where I'm leaning.
No, and I'm with you completely, and actually showed you why what you're doing makes sense. I mean, I showed you that with PTSD and ADD as a diagnosis, some components of them were not useful for intervention and some were, but you couldn't tell from diagnosis alone, but you need to intervene to change the outcome. And so part of it is figuring out how to do this. And so the diagnosis we have in mental health, because it's non-causal, it doesn't give you this. And part of it is wherever you are, you're classifying people based on the information you get about them. And what I mean, as I've said before, by classification, you take the information you get and you look at the kid and you say, are they at risk for this thing I'm worried about or not? So are they within a group of people, given my experience, that I'm worried about? And then classification, will they respond to this intervention I might think about or not? So the question is, the diagnostic system we have is really limited for that. So we have to figure out a system that is going to be better for helping us classify kids and families like this.
Thank you. So while we're waiting for other questions or comments in the chat or by raising your hand, just want to highlight that the feedback survey is in the chat. If we really appreciate your feedback. This is only our second one of these, so we're really, really interested. We took your feedback very seriously from the first one, for those of you who attended the first one. So please fill out the feedback survey while we're doing questions. And I will get to you in 1 second. And then also, the registration link for upcoming webinars is also in the chat. And if you're interested in CEs and you attended the whole session, you'll get a notification in about a week to register and get your CEs. And if you don't mind unmuting and asking your question or comment.
Yeah, so I was just wondering, in terms of determining what is red and what is green, did you use statistical analysis to do that? Or is it something else?
So right now, this is a hypothetical example that, there is going to be something that's true. And the way to know it's true is by using certain statistical and data science techniques to be able to know or model as closely as possible the causal process that generated the data. So we'll be talking about in next sessions what these techniques are, giving you different examples of different ways of getting models that look like this, because you need to use very specialized models. techniques in order to get that.
Okay, thank you.
Other folks with questions or comments, feel free again to throw them in the chat or raise your hand. I really appreciate everybody's thoughts and comments so far. And if you haven't, please fill out the feedback survey and register for future events.
And could I just say, debate is welcome. Like,
Yes.
if anyone wants to argue that, like this, it's hard to get this right. We're in a complex world. We have to figure out how to get it right. And so, you know, I love that we're a mixture of providers, administrators, and scientists here, and other people are represented as well, because the solution is going to involve us mixing it up, because everyone has a piece of the elephant, so to speak, to get it right.
So while we're waiting for any other questions or comments to come in, Glenn, do we want to just go through the next session real quick and ask people, just so
Yeah.
they know what that is, and then
Yeah,
if
and
there's
so
other questions, we'll get to them.
Yeah, so this is, looking ahead where we're going here. So we finished 1 and 2. Again, we introduced the concepts. Again, we're framing everything by what will be valuable for what practitioners need to help kids, all of that. Now, the next session, as I've said, it's going to be, okay, I've talked about problems with clinical application, how people might be thinking of this and tools they have. So the next session is about, well, what are ways to use causal and predictive knowledge in practice? And there's pieces of information, there's ways of using predictive tools, and to me, the most important thing, because in a complex world, we should expect that we're going to be wrong a lot. We try an intervention, then we don't keep it going in perpetuity or until someone drops out of treatment and all of that. We proactively look at it. Did change happen as we expected it would when we launched the intervention? And if not, what have we missed? So that's next session. And again, I'll give you very practical examples and tools for how you do this. Then we're going to be moving more into the science, and with an examination of our paradigm, including diagnoses, including the methods we use in our research, all of that, and looking at limitations. That will build to session 5, where I'll be talking about very powerful tools that will make a difference here, and how to use these tools to build knowledge that may put us in even a better framework to establish a diagnostic system based on causality. And then nothing matters, nothing, unless it can really help people in practice. And in the CHAMP Center, which is sponsoring this, CHAMP Center and CHAMP Network, as we've talked about before, it's all about using these models to build decision support tools that could be used in practice to guide decision making, as we've talked about. And our, our 6th session is going to be about that.
Thank you so much. And a reminder that everybody can register for any or all of those events through the link in the chat. We'll also include it when we send out the slides and the video from today's, which we encourage you to share broadly. If anybody has any additional questions or comments, again, please feel free to throw them into the chat or raise your hand. We appreciate all the folks who dived in today and raised questions and comments. And also please fill out the survey, the provider survey. I believe last time we sent it out after 2, but we always love to get them today, because I know that once you have left today, opening up a new email is always an extra challenge. So please feel free to fill out that provider survey or the feedback survey right now. and register for any future events. So I'm just looking through the chat and also for any raised hands. I am not seeing anything. Jen, I want to make sure I'm not missing anything before.
Yeah, there is one last question.
Okay.
Have you
Great.
considered how substance use might impact behavior in a diagnosis?
Yeah, I mean, that's a question. And again, it fits here as well. If you think substance abuse is important for any outcome, it's really an empirical question. We want to see it. It needs to be causal. It can't be a correlate or just a predictive factor. Certainly, I've seen it important for lots of outcomes. But again, we in this world, we have to presume nothing and really follow the data and the way we may practice where we're set to always be learning. And then about substance abuse, it's also, if you could then you could also put substance abuse as your maltreatment outcome, because it could be related to maltreatment, but it's the same thing. What are the causes of it? What are only the predictors of it? If I want to intervene to reduce substance abuse, I have to intervene on the causes.
That makes sense. All right, that was a really good question. I'm glad somebody raised that, because oftentimes we keep our mental health world on one side of the aisle and our substance use world on the other side of the aisle, and often they intersect.
And
So,
just one thing for everyone to think about is you could substitute anything for your outcome, anything you think is relevant, positive things, pathological things, negative, whatever words you want to use, and substitute anything you think is important, but it's still the same thing. It's still causality is in the middle of it if you want to change it.
wonderful. All right, I'm not seeing any more comments or raised hands, so I think we will give everybody, let them go back to their day. I really want to thank Glenn for presenting, and thank everybody for taking the time today and joining. We look forward to our next webinar next month. Again, all of the various ways to sign up for that. We like that we're carrying people from one to the other. I think that's really great. Fill out the feedback survey, and if you're waiting on CEUs, those will come through as well. So thank you everybody for taking the time to join today, and we look forward to seeing you at the next webinar.